Yes, thank you. Can you hear me okay?
Yes.
Okay, I'll go ahead. Good morning. My name is Dr. Marc Robinson. I'm a physician in Houston and Harris County. In my practice, I routinely care for incarcerated patients from our jail, mainly those who require hospitalization, but I have worked a significant time in jail clinics in the past. I'm here representing my own opinions, not those of my employer or the hospital system in which I work. I really want to thank Sheriff Rowe and the Commission for allowing my public petition to be placed on the agenda today, and for this committee for taking the time out of their very, very busy schedules to consider this. I know you all have a lot of other things that you could be doing. I submitted several rule comments and suggestions, and I appreciate you allowing a forum for comment to be made, but today I'm just going to be talking about my comment regarding family contact while a patient from a jail is hospitalized. I know this body has the unenviable task of taking petitions, comments, recommendations, and best practices and creating rules and regulations to facilities of all sizes and resource allocation. It's impossible work, and I'm just amazed by what y'all do. That said, I believe that whenever a patient is hospitalized with a serious illness from a jail, regardless of the setting and circumstance, it serves everyone, the jail facility, the family, the patient, and the hospital to keep the next of kin in the loop and updated regarding their medical care. As it stands now, most hospitals just defer to the jail facility of when to contact the next of kin, and typically contact's only allowed whenever a patient lacks decision-making capacity and a decision needs to be made, or a patient's very gravely ill on death's door. Obviously, these are very crucial times to contact a family, but it leaves out the many other times when it's still very, very important. So if a patient's sick and things could take a turn for the worse, if a patient's undergoing surgery or general anesthesia, when a patient has capacity to make decision but needs help making a decision, talking and discussing with loved ones during an acute illness, it's core to the delicate relationship that we have to build in the hospital and with patients. I remember a case where a jail patient was hospitalized for weeks and weeks and didn't have any of the criteria to contact family, so we weren't able to call them. And then they became very sick, very, very sick, and had to go to the intensive care unit. And then we had the ability to contact the family, and it was devastating for them. They asked us over and over and over again, why couldn't we be contacted earlier? And we as the medical team felt complicit in causing their pain. If we're only allowed to contact a patient when they're on death's door or after a complication for a procedure, then that the family didn't even know they were getting in the first place, it's going to be impossible to build that trust with families. I had another patient who was undergoing surgery due to a severe infection, and he wanted to talk to his family before the decision was made. He was not allowed to. I'm a doctor, I have decades of experience, and if I had to decide on whether or not to go to surgery, I would absolutely want to talk to my family first before making that decision. I lead a section of over 70 physicians. I've trained hundreds of doctors in training. Not being able to update the family is the most common frustration I hear about when talking about the incarcerated population in our hospital. And I must say that this is a population that our faculty and doctors in training routinely enjoy taking care of. It's cited as one of the best part of their jobs, taking care of patients from the jail. There's ample evidence that involving and updating families in care reduces the risk of lawsuits, improves the emotional well-being for families, patients, and staff. It's substandard practice to do anything else. So my suggestion is this, that family contact should be allowed and required for patients admitted to an intensive care unit, for those hospitalized more than 7 days, those undergoing anesthesia, or those experiencing end-of-life care. And I understand the security risk, right? Hospitals are non-secure units are vulnerable, and in many areas, jailed patients make up a tiny percentage of their population, so they're not as experienced with their care. And the last thing you want is the family coming without permission to visit, somebody in the hospital. Often the next of kin is a victim of a crime, and so that is a whole different layer of complexity. But these problems aren't insurmountable. Jails and hospitals can have a medical liaison who's trained in contacting families while minimizing security risks. Physicians can collaborate with the jail on who the best contact would be and call on a secure and recorded line. Jail chaplains or caseworkers or medical staff in larger jails can serve as a go-between. There's lots of solutions, but we just cannot continue with the status quo. So I ask that you consider implementing these common sense rules which would benefit patients, healthcare workers, but especially jails and hospitals. And I truly believe that this would be a net positive for absolutely everyone. So I really thank you for your time today, and I'm happy to help in any way. This population is very near and dear to my heart, and I greatly appreciate all the work you do for them. Thank you.
Thank you, Dr. Robinson. I appreciate your comment. I think we're going to address